Hello, everyone. Good evening. I'm Anne-Marie Pasco, Senior Director of the RLI, and I want to thank you all for joining us for tonight's RLI Leadership Town Hall, Leading in Times of Crisis. We know that schedules are really tight at the moment, so we really appreciate you making the time to join us tonight. Before I turn it over to Dr. Lexa to get things started, I wanted to tell you a little bit about tonight's program. After you hear from each of our 5 panelists, we'll be opening things up for Q&A. You can participate in the Q&A portion by either submitting a question or raising your hand. As you can see, we've taken a screenshot as an example of what you should be seeing on your own computer desktop in the upper right-hand corner. To submit a text question, just type your question into the questions pane of the control panel. You may send your questions at any time, and the moderators will collect these and address them with the panelists at the end. Or if you prefer to ask your question verbally, you may raise your hand by clicking on the hand raising icon on the Grab tab in the upper left of your control panel. When you're called on, the organizer will unmute your line so that you may ask your question. If you're muted locally, you'll just have to be sure to unmute yourself locally. One note about audio: when you joined today's webinar, you selected to either join by phone call or your computer audio. If for any reason you want to change that during the session, you can do so by accessing the audio pane in your control panel and making the selection you want. Finally, we have a big audience tonight, so I just want to give a reminder that the internet's a busy place these days, so please be patient and bear with us if we happen to run into any audio or video issues along the way. And with that, I would like to introduce Dr. Frank Lexa. He's Chief Medical Officer of the Radiology Leadership Institute and Chair of the Commission on Leadership and Practice Development for the ACR. Dr. Lexa, it's all yours.
Okay, well, thank you very much, Anne-Marie, and thank you to your team for pulling this together. And I also want to thank all of you who've come on to participate online, and most of all, thank our leaders. And we have 5 tremendous leaders who are going to be speaking tonight. These are all people who are, at the tip of the spear and who are doing things in a time of crisis. And leadership is always important. It's why we have the RLI. But particularly in a time of crisis like this, we really see the importance of leadership, and we really people step up and are tested as leaders. And my charge to these 5 leaders was to focus on some of the elements of leadership, some of the challenges they faced, and how they've been able to step up and succeed in what are very challenging times. And the first thing we're going to do before we hear from them is we're going to hear from you. And I will be turning this over to Jeff Rubin. He's a professor of radiology and bioengineering at Duke University. And he's not only a board member here at the RLI, but he's one of our really incredible faculty. And he's a tremendous teacher in the RLI. And we're going to give you a chance to tell us a little bit about who you are and about a little bit about how some of you are responding to the situation that we're facing. So I'm turning this over now to Jeff Rubin. Thanks.
Frank, thanks very much. And a big warm welcome to everybody from me as well for whatever you're going through in your local hospital, at home, families, friends. It's great that you're all able to take a little bit of time to spend with us and to spend with the fantastic leaders that we have. We're going to start by running a little bit of a poll. Just to get a sense of who you all are and what your background is. So I'm just struggling to advance the slides right now. I think somebody still, other than me, has control of them. I see another mouse moving around. Oh, okay, there we go. All right, excellent. So the first poll question is to find out whether or not you are a trainee in private practice or academics. What is your practice setting, please? And I see the votes coming in. We're doing pretty well. Hopefully everybody has found the interface and such. Please don't hesitate to make your selection. We won't be posting your personal results on the internet. I think this is good. Why don't we show the results to everybody? Let's see, that's for me to do, I think. So here we are. So essentially, we have almost about 16%. 16% are in training. And then amongst the rest of the radiologists out in practice, 50% private practice, 50% academics. All right, let's go on to the next question, which is for you to indicate your practice setting, your professional setting, urban, suburban, or rural. So here we will launch that poll. And please give us an indication of where you practice. We'll just give it a few seconds to allow people to provide their vote. I see the numbers still coming up a little bit. Okay, that's great. That's excellent. So let me share those results and show that we have an urban dominant group here today, 33% suburban, and just relatively small number of folks with rural practices. Okay, great. Our next question is going to be, are you reading your cases, the work that you're doing when you're doing radiology from home, from the hospital, or someplace else? And by hospital, let's consider this, you know, if you practice in an outpatient center or at an outpatient clinic, let's include that with hospital as well. So let me launch that one for you, and please let us know, where are you currently reading cases? Okay, so most folks are still in the hospital, are working in the hospital, 2/3, about 25% from home, a few other alternatives. Very good, very, very helpful. Next question. How many COVID-19 cases have you seen? And by seen, interpreted imaging studies of, or if you're an interventionalist, done procedures on within the clinical context. How many? Let me launch that one for y'all. Okay, please let us know. How much COVID are you all seeing out there? Okay, I'm going to close that one and share the results. And a pretty diverse set of experience, almost equally distributed across the various categories. About a fifth of the group has seen more than 50 patients. So that's you know, pretty substantial volumes. And there's still about 20% who have yet to see their first COVID case. Certainly reflective of the distribution of disease around the country. Okay, so the next question relates to if you are working in a hospital, do you have adequate PPE? And you know, a large number of folks, 2/3 are still working in the hospital. So please let us know about the environment that you're in, whether or not you have adequate personal protective equipment, and you've got the face masks, face shields, gowns, gloves, whatever is needed for the types of procedures and interactions that you're having with your patients. Okay, I'm going to share those results, and it looks like about 3/4 of folks do, 23% do not, and you know, when we get to the question and answer period, and we've heard from some of our leaders, this might be a topic that's ripe for discussion, is managing to practice effectively to maintain your safety, the safety of your staff, technologists, of nurses, the safety within the waiting room, for patients that when there is insufficient PPE. We have one more question, and then we will transition back to Frank to introduce our leaders. So the last question, has your practice received the advance payments from the Department of Health and Human Services? Oops, let me get that poll launched for you. There you are. Has your practice received any advance payments from HHS? Okay, looks like we've got a pretty stable result there. And it looks like about 35% have, 65% have not. And so that is an excellent overview. Thanks everybody for participating and providing us with that context. And let me now turn the podium back over to Frank, and I'll be back with you to moderate the Q&A after we've heard from all of our leaders. Frank?
Okay, well, thank you, Jeff. And I'm going to make this very quick because I want to get right to the leaders. But we have 5 tremendous speakers. Each of them is going to talk to you for about 10 or 11 minutes, and then they'll be available for your questions and comments. And we're going to move right into it with our first speaker, who is Jake Chasm. I have control.
Hey, everybody.
And I'm turning it over to Dr. Chasm.
It's really such an honor to be here and speak with you all about this. Jacob Kazam, I'm in New York City, where we've been at the epicenter of taking care of a lot of these patients during this outbreak. And I hope that some of our experience can really help. I'm relatively junior. It's only my 4th year out. And I'm in a vice chair of operations role that I just recently took over. And so every day has been a learning experience for me, and certainly the last few weeks have been a tremendous learning experience. So I wanted to talk about some just basic themes and takeaways, you know, based on this whole crisis, and just give you some examples of, you know, things I thought we did well, things that maybe we could have done better, that sort of thing. So the first thing I wanted to focus on is the importance of communication. You know, and my initial instincts on this were a little bit wrong. So very early on in this process, we had our hospital leadership giving us daily updates with, you know, video. We had our medical college dean giving us email updates, and very frequently had a video in there as well. And I'm sure just like you all, you know, every single vendor or business that I've ever even, you know, clicked on their website has been sending me email about what exactly they're doing on COVID. And, you know, I felt like we were totally inundated with information. It was too much information. And we were at a strategy meeting, and our chair asked, you know, are we communicating enough? And my initial instinct was that that's a crazy question, because I just felt so inundated very early on with COVID related information that I really couldn't think about the other aspects of our jobs. But I quickly learned, based on feedback from, you know, other people in our department, that we were not communicating enough. And the reason we were not is because people really want to hear from leaders that they know. They want to hear from people that they're dealing with on a daily basis, that are aware of their situation. And they also want to hear from people that they can freely ask questions to. So that's definitely something that I learned, is to, you know, in a crisis, you have to communicate early, communicate often, and you have to allow for question and answers. So, you know, the first email update I sent out, which was pretty early on, I got a lot of responses to that, just saying thank you for the communication. So clearly there was a need there. And we very easily convinced our chair, who's super, super busy because he has some other roles as well, to spend some time with video conferences with our department. And, you know, he went above and beyond. We basically asked him for a small chunk of time, and he doubled it. And he has been holding twice weekly, 1 hour long sessions with our department, where he gives a high level update and then asks for a Q&A. And that's been a huge boost to morale, just knowing that leadership is available and thinking about these things, you know, the specific issues that are coming up within a department, and dealing with all of that was a huge boost to morale once we started doing that. On another level, without involving our chair, we did similar sessions as well, for some of our nurses and our technologists, just to be available to update them and to answer any questions. And I can tell you that in the beginning, there was a ton of questions. And as time has gone on, the questions have gotten less and less. And that tells me that, A, people have been comfortable to ask questions, but B, people are feeling heard. And I think that's great and something that perhaps we could have done a little bit earlier. The next thing I wanted to touch on is managing based on incomplete and constantly changing information. So, very early on, we had totally different screening guidelines for our patients. We weren't at community spread yet. We were asking about travel history. We were asking about certain symptoms like fever. And it quickly became apparent that that wasn't really working. We ended up having community spread, and those symptoms were much, much more broad. So, also like the use of PPE that has evolved over time. And, what we did is we just kept in constant line with the greater institution. And one takeaway from this also is to make sure that our technologists, our staff, our nurses, our residents, our radiologists that are in the same patient facing areas as everybody else are treated the same way as everybody else, that they have the same protection as everybody else. So as an example, our technologists in the ED, they need to have the same level of PPE at the same time as our ED providers, because they are ED providers. And the same thing, one of the things that I'll touch on is we sent technologists to certain clinics that we have, our cough and fever clinics, to take portable x-rays. Those technologists should have the same level of protection as the other healthcare workers in those areas. And, it might not be totally in line with the greater institution, depending on what they're doing. But, I think it's important that they're seen as equal members of the team and that they're treated equally and that they have equal layers of protection as everybody else. And in a crisis situation like this, things are going to change, and it's obvious to everybody that we're changing. And I think we just need to vocalize that and say, we're making a change and this is why, and it's based on whatever. And then we can move on from that. One other example of managing based on incomplete information is something we're still going through now. We have some technology, we have some residents that are redeployed. We have some nurses that are in very, very high demand and they are redeployed. The residents and nurses redeployment was handled a little bit differently. So our program directors were gigantic advocates for our residents. And initially the hospital wanted 4-week deployments. And our program directors pushed back a little bit. Obviously you want to train up healthcare providers so they can provide a high level of care. But also at the same time, you don't want to totally overburden them. And so they pushed back and asked for 2 weeks instead of 4 weeks, and they got 2 weeks. Our nurses have been out a little bit longer, and now we're talking about a way to kind of rotate them through to get them in line, because it starts to become unfair when certain healthcare providers are not doing the same amount of work as others in a crisis like this. Another point that I wanted to touch on is relying on others. So we have a very hands-on chair. He's very big picture, but he's also very detail-oriented, talking about colors of couches and how they, work with the aesthetics of our outpatient imaging center. He's gotten even more busy, and he's subsequently more reliant on people like me. And, people in my position were more reliant on our division chiefs, our individual faculty. So I'll give you an example of that. One thing we started doing very early on is rescheduling non-essential examinations. And we built a team around this. We had, we decided non-essential exams were those that can wait about 8 weeks. It's a little bit of a guess, an educated guess. But we needed subspecialty expertise to decide what can wait 8 weeks. And that's where we involved our division chiefs. We needed expertise from our call center into what the best way was to get these exams canceled or rescheduled. And of course, this isn't a perfect process. So we made radiologists available to speak with patients who had questions about why their exams getting canceled. And that also gave some of our radiologists more things to do during certain hours of the day where we were seeing less volume. And these same teams, I think we can use towards the recovery stage, which is going to be useful in the future. I also wanted to touch on just leveraging strong relationships. So if you have an existing relationship during a crisis, it could potentially be very valuable. So we work, for example, very closely with leadership in the ED on a variety of projects. We meet on a monthly basis. We're in constant communication. And because of that, and because of the trust that we have with each other, it was very easy to get them on board with the ACR recommendations around appropriateness of imaging. And there was no fight whatsoever about it. And I think, consequently, we're doing a lot less imaging than, some other sites or medical centers because we're able to be on the same team and we have that trust. We also have a strong relationship with our outpatient centers in the physician organization. And because of that, we were able to very early on deploy portable X-ray units to those cough and fever clinics. And this way we keep the patients at the cough and fever clinic. We're not sending them to an additional place like an imaging center to get imaging that they may need. And we're not sending them necessarily to the ED to get imaging that they need. So those were hugely valuable. And I think this is also a time to form new relationships. Like the Department of Psychiatry prophylactically reached out to us and they asked if we needed help and they set up a town hall for us. And that was hugely valuable. And that's a relationship that we're building during this crisis. And I think it's something that we will be, that will grow afterwards and that we'll be better at in the long run. And that's another thing I want to quickly touch on before I close is when we're doing any of these things as leaders, I mean, for me, it's so helpful and motivating when I'm not looking at a task as a temporizing measure, but looking at a way to make things better in the future. So an example of that is teleradiology. It's something that we've wanted to expand for a while. And this was an excuse to really expand it. And we got we got workstations that really I'm proud of that work really well. And we got VPN, we got lots of different things that are going to help us in the future. We built these teams to reschedule non-essential exams. We're going to have teams to decide on what the best way to reschedule is. We have these robust educational efforts that have grown out of this process that are only going to help us in the long run. And I think you look at this through the lens of improving patient experience. So when we recover from this, we're going to want to spread out exams. We're going to want to continue to de-densify our waiting areas. So that's going to involve things like checking in patients in a more efficient way, leveraging online check-ins and safety forms so that patients aren't in the waiting area filling these things out, optimizing our protocols so that we can space these exams out. And ultimately, that's going to lead to a better patient experience. And I'm happy to work on those things. Those are going to have a lasting effect for our practice, and we're going to be in a better place, I think, in the long run. And then also, I think it's important to take care of yourself. And, when you get busier, there's less time to do certain things, that help you decompress. Like I love to play music. I exercise a little bit. I don't love it, but I try to do it. And I've been much more regular about exercise, and I've been much more regular about, playing an instrument because it really helps me decompress. And, I think that those types of things become even more important and have helped me a lot in this time. So thank you for the time, and I will hand it off to our next panelist.
All right, thank you so much. That was great. And we're going to move forward now. And we're going to ask Dr. Masabasha to speak to you. He's from UW, and we're going to turn it over to him. Thanks.
Thank you so much, Dr. Lexa, for the introduction, and thank you for including me on this panel. In terms of our experience through this COVID process, as you know, University of Washington and Washington State and the Seattle area was the first area to be hit by COVID and the first area to have a COVID outbreak in the United States. So we got a little bit of a early start in regards to addressing these issues and a little more time to go through our iterative process to get to where we are now. In addition, we hit our peak according to our global health group through the University of Washington. We hit our peak on April 2nd. So we've also been starting to look forward and look over, down into the valley in terms of the recovery phase, probably a little earlier than a lot of other people have as well. And so in terms of our approach, in terms of policies similar to Jacob, I've been responsible for putting together these policies and guidelines for our radiology department. It's really been through a lot of coordination with our hospital leadership for development of policies, putting together things from the CDC, as well as other organizations. And this has been a rapidly evolving process, as it has been, nationally in terms of the CDC and in terms of other organizations and their understanding of this disease. As that understanding has changed, our policies have changed as well. And this has led to a very dynamic process that's required a lot of people to be very nimble in terms of both those changes, as well as incorporating them into policies and acting on them. Through this, we have been providing, since the beginning of this process, weekly email COVID policy updates, in which we include our main document and other supporting documents, as well as bullet point changes that have occurred and things that have been added. And this has coincided with hospital policies in addition to our own additive policies included in there. And similar to what the Cornell guys have experienced and Jacob has experienced, this has been very well received. And people certainly read our concise bullet points much more closely than the hospital-wide emails. A lot of times, which are, I think maybe are addressing a wider audience, and a lot of times include a lot of information that is very difficult to quickly digest. In terms of our leadership and our approach, we've also been looking to reduce tensions and anxieties within our department. These have been very high, and there's a lot of concern about potential exposures and what this really means. So our goal all along has been to listen to people's needs, support their concerns, but at the same time, work to reduce that anxiety and concern by helping everyone realize that, what you're seeing on the news isn't, may not really be as bad as it really is. Understand that you need to take the precautions that you do, but if you take those precautions, you will probably be in pretty good shape. And there have been a lot of, concerns that really don't match reality that arise, especially, and I think those are human nature in regards to those coming up during the setting of crises, but really to calm people's nerves in that regard. And that's been through communication, and we've approached that through a lot of different avenues. We've held the weekly enterprise-wide faculty meetings in which we discuss, information that we've gathered, discussions that we've had with hospital leadership, infectious disease and pulmonary disease leadership, and as well as having an opportunity to hear faculty's concerns and to get their input in terms of what we're doing. We have a daily, initially for the first few weeks, we were having daily leadership COVID huddles to disseminate new policies and information to section heads, as well as other leaders, and to check on section morale and health, as well as to communicate positive COVID cases that have come up within our healthcare workers and our employees. In addition, we've promoted weekly Zoom meetings for sections to hold in order to check on their membership, considering now a lot of people are working from home or they're working from single workstation reading rooms, and we may not see each other quite as often. So it's a good way to maintain that connection and maintain that morale. In addition, we have been creating policies that work towards easing concerns and tensions sensed by the faculty, as well as to work towards protecting them. Early on, we employed policies that allowed healthcare workers to wear surgical masks while in the hospital, initially during all direct patient care, but then, allowing employees to wear masks, as they see to be needed, whether you're sitting in an office or in a reading room. We've encouraged people to wear masks. We've allowed people to work from home, especially those that are concerned about their health or have a higher risk of poor outcomes from exposures. And we've also established a lot of single workstation reading rooms across our enterprise. We've established 21 reading rooms, both within any of our 6 hospitals, isolated rooms, or within any of our 4 outpatient imaging centers. With that, that's kind of decompressed the reading rooms. Within the reading rooms, we are focusing on what we call extreme social distancing, where we've reconfigured the reading rooms and really make sure that there's as little people as possible within the reading room and they're sitting as far apart as possible. So generally those teams are made up of 1 faculty, 1 resident, and 1 fellow in the reading room at any given time. And we've really focused on reducing that presence to protect people, and also providing people with a flexible environment to work, working from home, reduced shifts, really to help them feel comfortable in terms of what they're doing and the environment they're in. And generally, I think throughout this process, just being supportive and listening and understanding those concerns and addressing their concerns in a way that they feel like that they understand that they're being heard. In addition, we've worked, my chair and I have focused on showing people that life goes on as usually despite the crisis, in order to and making efforts to try and address people, kind of take people's mind off these things. People right now are focusing a lot on COVID and what this means, and it's really, with sports out of the way, with work volume maybe a little lower, the national pastime has become COVID. So we're trying to create opportunities to focus on other things. We've created a virtual grand rounds program that we hold 1 to 2 times weekly, where we invite national speakers to give a virtual lecture to us. And we've done a number of these, and we plan on continuing this process, both throughout the COVID environment and the COVID period, as well as beyond that. And the plan is to create a permanent program that's like this. And 1 to 2 times a week, we have that speaker. And we've also had people to start focus on what we'll be doing in the post-COVID environment. Starting to engage people to start planning for our fiscal recovery. We've been engaging people to serve on task forces. These include initiatives to mitigate costs in the short term, plans to grow business going forward, as well as that generally planning for that post-COVID environment in terms of things like waiting rooms, workflows, all those sorts of things. And it's been nice engaging the faculty and staff in regards to this process, and it really is a learning environment for us in terms of maybe delegating some of that leadership and some of that innovation, because it's led to many interesting solutions. One of them being imaging patients through glass using portable X-ray equipment, and that was something we published in our radiology paper recently, and it's something that's been very well received. In addition, we have really seen this as an opportunity for improvement and an opportunity to strengthen our department, similar to what Jacob was talking about. Virtual education has really enhanced our ability to educate our residents and faculty. Outpatient imaging center expansion for better financial strength going forward. Homework environments for a more flexible work experience for our faculty. Population health efforts, as well as leadership growth and development within our faculty. In addition, we've worked, my chair and I have worked towards leadership by example. We have both made an effort to, while maintaining all the best safety practices in terms of social distancing and in terms of masking and all that, but we've been trying to be present as much as we can within the hospital, going into the reading rooms, checking on people, making sure people are comfortable, listening to them, reading out studies to provide support during the daytime. And we've been doing that from when this crisis first started through beyond the peak that we experienced. In addition, rounding through all of our hospitals and going around and checking on the technologists and the nursing and the other healthcare workers within radiology, making sure that they feel supported and that they really realize that we really do appreciate their efforts and that we're listening to them and their concerns. And this has really led to a lot of policy modifications in terms of our approach of things. In addition, I think another concern that's exists across all radiology departments is financial anxieties. And we have really focused on making sure that we protect our faculty and staff salaries as much as we can throughout this process. And that's really been a central focus on ours. We've put forth financial mitigation plans that don't include salary cuts. And we've also engaged a lot of our faculty and a lot of our leadership to come up with innovative ways in which we can save money in the short term. We've also put forth diversification plans for faculty to think about and engaging them in ways to grow our business, to mitigate our losses. We've really tried to focus on positive growth as opposed to ways to negatively reduce costs, especially in terms of salary reductions. Now, in terms of difficulties that we've run into, there have been a number of them, obviously. With a large system such as ours, as I mentioned, 6 hospitals, 4 outpatient imaging centers, it's been difficult navigating, maintaining, and coordinating policies across these institutions because many of these institutions have separate governorship and our governance, and really coordinating in radiology, kind of maintaining our policies across institutions became somewhat challenging. Over time, those policies all did come together, but it did take a little bit of time. And in addition, as I mentioned, there was a lot of anxiety early on, and it was a challenge to really ease those concerns and maintain in-house coverage. When this issue first started, in some sections there was a lot of concern, and when the option of working from home became a possibility, a number of sections said we were exclusively going to work from home, and we're going to leave the trainees to cover the reading room, and we're not going to do procedures anymore. And this was, you know, it's not necessarily the best messaging that we want to send to the hospital. So through communication, through education, through discussion, we've really been working to get through this. But this is certainly not the message we want to send to our trainees, our frontline tech workers, and our non-radiology physicians. And so, you know, through this process, we've really worked towards overcoming this challenge. In addition, we have faced the challenge of, you know, when healthcare workers test positive for COVID. And we have held virtual meetings with the whole team, such as if a radiology MR technologist tests positive. We've held group meetings with all the technologists within that hospital to address their questions, to really address their concerns, and really have just an open conversation about it, and really to support them. In terms of things that have worked very well, I think our virtual education program has really taken off. We've had much better attendance, not just for the virtual education components, but also for our conferences, for our multidisciplinary meetings. All those have really had increased attendance as well as increased engagement. As I mentioned, we're a pretty geographically dispersed group. So with that dispersion, it becomes difficult for people to tune in person. So this has really facilitated that process. And through the virtual grand rounds that I mentioned, we've really been able to engage speakers from across the country. We provide daily communication and dissemination of policies and procedures through the leadership, and that's gone very well, and things have disseminated very quickly. And in addition, we've had great coordination with hospital leadership in terms of our policies and in terms of getting their input on what we're doing, and also the opportunity for us to provide our input. And our operation teams have been very facile in terms of incorporating new workflows. In addition, I think everyone has been very engaged, and we've really had a great unified approach and a motivated, cohesive, enthusiastic team focused on improving patient care, protecting patients and healthcare workers, and standardizing our processes across our enterprise. I think in times of crisis, you really see what you are made of, and many of our healthcare workers and leaders have really risen to the challenge. I do want to say, you know, we have, you know, overcome our COVID surge, and we're really looking, as we mentioned, down, you know, down into the valley to really see what the future holds, and you know, and we're looking upon it with a lot of optimism. We're really, you know, looking positively towards it. And for those that, you know, haven't gotten over that hump or are in the process of dealing with the surge, you know, we're going to get through this, and I think we're all going to learn a lot about our practices, and it's really is an opportunity to get stronger and more resilient. And engagement from team members has really helped us through this process.
Okay, thank you very much. That was great. Thanks.
Thank you.
Now we're going to go to Dr. Daniel Ortiz from Summit Radiology in Georgia.
Hey, everyone. Thanks for having me on. So I'm a first year radiology, private practice radiologist in a small to intermediate sized group of about 23 or 4 radiologists. We cover a fairly wide geographic area. Our farthest hospitals are about 232 miles away from each other in Northwest Georgia. So the way I got involved, as you can imagine, I don't have any formal leadership roles in my practice or in any of the hospitals. But my involvement in COVID-19 response really stemmed from happenstance that I was at the hospital that would eventually become the site of an outbreak in our area. And I was going to be the diagnostic radiologist at that site for the next few weeks. And in the first couple of days of the outbreak, it wasn't recognized yet that a COVID-19 outbreak was occurring. This was in early to mid-March. It was way before anything was anticipated in our area. One of the things that kind of made us recognize that we were having a local outbreak was the imaging that was occurring in patients that came in with acute respiratory illness. Had the typical atypical appearances that a lot of the papers out there have described. And piecing that together with our clinicians on the front end, piecing stories together, they realized that one particular local church was the sort of epicenter or epicenter of the local outbreak. There was a church event that brought in people from all over the country, which ended up being the nidus for our local outbreak, and that took a couple of days to really recognize what was going on. One of the early lessons, more on the clinical side, that our hospital realized was that these patients were not presenting with the typical symptoms that was described by the CDC. A lot of the patients weren't being screened positive using the CDC guidelines. And after they added attendance at this church to the screening process, they started screening a lot more patients as possible, or patients under investigation for COVID. So in the couple early days, I was one of the first ones to have to really deal with the clinical practice of dealing with these COVID patients in my group. So obviously I was scouring the internet, trying to understand and learn everything that I could. And I began to save cases using keywords on our PAC system for patients that were patients under investigation that had typical looking findings, just to sort of have a database for our local radiologists to kind of get an idea to really scroll through a couple of these cases to better understand everything going on. And early on, I looked at the ACR guidelines and I saw the recommendations for fairly limited imaging in these patients. So I got a hold of the contact information for CMO of this hospital, and I called them up and I started talking to him. I presented, the guidelines and provided some education of imaging side of the COVID response to him, because I wasn't exactly sure what he had heard and what his experience was, because there was sort of a disconnect with what the recommendations were saying and what was happening at my local hospital. So I wanted to get down to the bottom of this. So I started the conversation off saying, hey, look, I think we're doing too much imaging on these patients, and guidelines are recommending this. And it was through that conversation that I came to realize that we were having a really big backlog in our PCR testing. We were waiting about 10, 12 days. And for them, in trying to triage these patients, they felt it was helpful for them to have at least something to help guide them with full understanding of all the limitations involved. So it was through that organic conversation that, we had, developed a mutual understanding of how we would proceed. We talked to a couple other clinicians, ER docs. Some clinicians had very different opinions on whether they wanted to have COVID-19 reported in their reports. There was fears about scaring patients or PPE considerations. So we eventually, after discussion with all of these teams, arrived at a process where we would use standardized templates for COVID reporting, our sort of judgment call suspicion level based eventually based off of the RSNA guideline recommendations for reporting. But this process had to start preceding that. And we developed a process that we would report our level of suspicion if the clinicians would provide COVID-19 confirmed or PUI in the indication, in addition to the regular ICD-10 code. One other thing that we realized that was going to help, after a discussion I had with one of our head CT technologists, was that especially in the first couple of days, there was a lot of missed communication between the ER and the radiology department with regard to whether a patient was under investigation or not. And by implementing this process of standardizing if the patient is PUI or COVID positive, every single rec has to have this in it. It helped protect our techs on the front end. So let's see. As far as operationally, we already had home workstations, so it was pretty quickly readily apparent that with our volumes going down because of canceling outpatient imaging procedures like the guidelines recommended, that there was going to be a contraction of volume. So, and to minimize our exposure to our radiologists, our IR guys and our mammographers kind of took the lead on this and became the main people going to the hospitals. The diagnostic guys, for the most part, started reading from home at that point. Our IRs took over all the fluoroscopy and all procedures, etc. Ended up canceling a lot of the outpatient procedures the best they could. In fact, our practice president, who's interventional radiologist, used the SIR toolkit to make some modifications and create our own 3-tier process of approving procedures. Either procedures that should be postponed for a couple of months, procedures that could be discussed by interventional radiologists to see if it was worth going through, and weighing the risks and benefits, and also things that had to be done emergently. So we provided those resources to our hospital. And with the contraction of volumes, obviously everyone had financial implications of that, and especially in small groups, things have to cut somewhere. And I was fortunate that the leadership in my practice, our partners, were willing to take the financial cut in the short term and provide stability for us associates and employees. And that was something that I felt was a very strong leadership move on the part of my practice partners. And for those out there considering how to manage and balance the benefit for everyone in the group, the partners in turn were able to take some more personal time off to compensate, since a lot of the work lists were fairly low volume, and we were able to condense 2 or 3 seats since we had home workstations, and we had the IT support already to read for several sites at the same time. Let's see. So as far as some resources that I used early on, really relied a lot on the resources through the ACR, RSNA, ARS, etc., but also ACR Engage, and actually Twitter was a good resource for me to engage with other radiologists around the country to figure out best practices. One thing that we took from this one endemic site, because again, our hospitals are 232 miles away from the two farthest hospitals. So even though we had an outbreak in one hospital, most of the other hospitals, the other 7 that we served, didn't have any cases at that point. So a lot of lessons that we learned at this one hospital, we were able to have a value added to the other hospitals in discussing with their administration as to best practices and things that worked and things that didn't. And we were able to provide those considerations for them to sort of have the starting point a little farther along when those hospitals eventually did have some new cases. You know, I really find these sort of unexpected crisis moments a equalizing event. Obviously, people that have had exposure in similar situations, their experience is crucial in providing best practices and moving forward. But this is an event that everyone hasn't had a real experience with. So the traditional considerations of leadership hierarchy can be loosened a little bit. I feel like anyone in a practice could develop to be a leader in this particular space, as long as you keep up understanding and learning as much as you can, keeping engaged with national conversations, because it's a very dynamic situation, and it requires frequent communication with the hospital administrators, with our technologists, and with our partners to make sure that everyone is on the same page, because things are just changing way too frequently to sort of get said in one way and carry on in that fashion. Let's see. I think that was about the extent of what I want to get to. Thank you.
Great. Well, thank you very much. And we can go back one. There we go. Next, we're going to have Dr. Dana Smetherman from Oxnard, New Orleans. So welcome.
Thank you. And like everyone else, thank you so much for giving me the opportunity to speak with everyone tonight about our experience. So we had our first case on March 9th, and we didn't know it at the time, but Mardi Gras, which happened about 2 weeks before that, was really a petri dish. And it has been fascinating to watch epidemiology in real time as this virus has moved through our community with just mathematical precision. For those who may not know, Oxnard is a health system. We have 19 owned, operated, and managed hospitals in Louisiana and southern Mississippi. And although our case numbers in the state, we have about 22,000 cases of COVID and about 1,150 deaths, are dwarfed by some of our larger states. We are actually third in the country in both the number of cases and the number of deaths per capita. Another interesting thing, and I'll get back to this, is that we actually had the highest rate of testing per capita. And I think that that's been something that's been extremely helpful for our community and our health system to navigate this situation. To give you some idea of the scope of our institution, we actually are taking care of about 60% of the inpatients in the greater New Orleans area, and the greater New Orleans area has the highest concentration of cases, more than 50% in the state. And if you look at the whole state, we're taking care of about 30% of the patients. So we also are slightly past the peak. It was about a week ago. At that time, we had 900 patients, COVID patients, in our hospitals. We don't have very many patients under investigation because and I'll talk about this in a little bit, we quickly got our own in-house testing. We are down to 691 inpatients today. As far as the state of the whole community, our mayor extended our stay-at-home mandate yesterday until the middle of May 16th. Our governor canceled school for the rest of the semester yesterday as well. And probably, if you know anything about New Orleans, maybe the most crushing fact is that they have canceled all of the festivals for the remainder of the year. So when I think about how I have approached leadership in this crisis, as the other speakers have said, it is all communicate, communicate, communicate. And I think you have to use virtually every channel that is available to you. I round a lot. I go and make sure I'm seeing everyone, and I ask them, what do you need? I'm on the phone with people, I'm texting people. We have virtual staff meetings at least once a week. I also use our Epic secure chat to communicate with my colleagues and to communicate with the techs in the room so that we minimize the amount of just personal interaction between people, also our colleagues across the system. And we're using Zoom conferences for all of our leadership calls and for all of our resident conferences and our multidisciplinary conferences. I think that as several other people have said, that as a leader, your physical presence in a situation like this, which can be very scary and can even be dangerous, I think that is absolutely critical. I think it would be very difficult to lead something like this remotely. So I think your team really has to feel like you are there for them and you are there alongside them. I also said that we were not going to be using our residents and techs as human shields, like as several other people said. And I think you have to show the entire time that everyone's safety is really your first priority, the safety of our people, and of course, the safety of our patients. Another really important trait, I think, to lead in a situation like this is humility. I've had to acknowledge that, my decisions are a best guess. I don't have months and months and months to come up with a fabulous strategic plan and an implementation plan and a bunch of meetings. And I've also told people over and over again, I'm not going to be perfect and I'm going to make mistakes. So, and I think people at least appreciate that you're able to show your own clay feet. I also think it's important, however you can, to find positives and express gratitude, and if anything, over express gratitude. So we not only in our meetings talk about the number of patients who have maybe died or who are in our hospital or on ventilators, but we talk about the number of patients who have been discharged, and we now have over 1,500 who have been discharged. We celebrate patients coming off of the vents. We have celebrated the fact that we have decreased ventilator utilization, and we're managing more and more of our patients with non-rebreather masks. And one of the things that's been very interesting is our facilities team has been very, very quick and facile at building out ICUs, putting windows in every door for the COVID patients so that they can communicate easily. Doing things like making sure that we have an iPad. We actually had an iPad give back program so that all the COVID patients could have an iPad in their room to communicate with their care team, but also most importantly, I think, to communicate with their families. We also have found many, many ways to provide recognition for our people, particularly the ones on the front lines. We have daily healthcare heroes that are celebrated in emails to all of us and also on social media. One of these actually was recognized by Jimmy Kimmel, so that was a nice little coup. All of our employees are now being given the option to have a sign that says an Ochsner healthcare hero lives here. And we are also all going to get t-shirts. After Hurricane Katrina, we all got t-shirts. And now for this, they announced today, we all had to send in our size of t-shirts. We've also leveraged our relationships with some of our partners. So we do all of the healthcare for the Saints. And so we've had Saints players and the coaches and the owner, Gail Benson, give video messages. Some of the Saints players have also donated food. We have had a tremendous outpouring of support from our community, which I think has really been gratifying. We all keep joking that it's unbelievable, we're probably going to gain weight in this situation because so many people have donated food. We also have had community support in things like from very early on, community members, the breweries, changed over and started making hand sanitizer. There were local designers or clothing makers who switched over to start making reusable gowns and PPE. And that's really been wonderful to see. And I think as challenging as this situation is from a morale standpoint, things like this have gotten people through. And obviously we have had some significant challenges. Candidly, our situation was pretty dire initially. Our cases were doubling in less than 2 days in mid-March. We basically, for the first 16 days, we had to add a new COVID service every day in our flagship hospital. We've had to double the number of ICU beds. We had, as I said before, had to build negative pressure rooms. Also, like many of you, we had hoped that we would be able to get home workstations. We had a few that we had piloted and we thought, okay, this is a great opportunity. We'll try to expand that. But candidly, our institutional IT resources were really being used to do things that were far more important for the front line so that they could have virtual communication with the patients in the rooms, the COVID patients, with ED patients as they were triaging them. Also with setting up telehealth visits. So we kind of had to recognize that our risks were lower than some of our other colleagues and wait our turn in line. We've now been able to deploy about 15 home workstations. We have a department of about 70. But we did very carefully, when we realized we weren't going to be able just to immediately deploy 50 home workstations, we went through and made sure we had plenty of social distancing in the reading rooms, taught everyone how to communicate and set examples of ways to communicate virtually with technologists and our referring clinicians, and basically put out a very robust communication plan that went to all of our referring providers to minimize the number of people coming in and out of the department and the reading rooms. I also think one of the real challenges, and others have talked about this, is just the psychological effects that this has on our colleagues. We have had the luxury of living our lives in the age of antibiotics and vaccines, and most, if not all of us, have never had to face this kind of really epic biblical threat, which our ancestors had to face. There's a high rate of death. It's contagious, and I think also knowledge is evolving. We are all really accustomed to having very rigorous scientific data, and this uncertainty, I think, is very troubling for our colleagues. I can tell you candidly, when I was rounding in the early days of this, which of course now was 5 weeks ago, but it seems like a year ago, I found people in tears in the reading rooms. I found others that were very agitated and obsessed about the risks, even if logically their risks were very small. And so we were also fortunate, in part because of our previous disaster experience with Hurricane Katrina, that we had a very, very robust employee assistance, stress and psychological assistance. We have quiet spaces, and there are hotline numbers. On the floors, actually, there's either a social worker or a psychologist that's on every team that's rounding. But I would also encourage you, if you have these resources in your department and you find that members of in your institution, and you find that members of the radiology department seem to really be decompensating, absolutely encourage them to take advantage of all of those resources. As far as what's gone right, I'm fortunate in that I am not only the chair of radiology at our flagship, but I'm also an associate medical director for some other medical specialties that included emergency medicine, hospital medicine, pulmonary critical care, and ID. So we were able to work together and get order sets that were sent out through the entire system for every ED patient, every hospital patient. There was also a lot of buy-in that this was not business as usual. So we'll have patients on vents that are maybe only getting chest radiographs every 4 or 5 days. We're doing very targeted ultrasounds. We, unlike Dan, because we had in-house testing very early, we did not have to rely on CTs for diagnosis very much. And I think that that has helped us preserve our PPE and also reduce our exposure. What other things went well? I really cannot stress how incredibly important it was for us to get in-house testing rolling very quickly. We have done 20,000 tests, and we can now do more than 1,000 tests daily. We have the 5-minute test that's used in our ED, so we can immediately triage patients, COVID or not. We have a 45-minute test that we use for all employees, so we know quickly are they positive or not, and we use that one in our drive-throughs. We have multiple drive-through testing sites, and then we also have the 24-hour test, and we have tested all of our inpatients, and we're also now testing all of our surgical patients, all of our breast biopsy patients, because we do have some category 5 patients that have to be biopsied through this, and all of our interventional procedures. Just a couple of last things that I think were successful for us. As a system, we had really robust analytics that we shared with the city and the state, And so we were able to look at ventilator management, not just across our system, but across the whole city. And we watched our R0, which is the number of patients one patient infects, go from 3 down to 1.2. So we were always below the maximum capacity, which was great. We've also had a very, very active supply chain. So we started asking for additional ventilators before we even had the first case in the state. Our Innovation Ochsner group started 3D printing face shields, so now all of our techs have those. I talked a little bit about the hand sanitizer and the gowns. Also, when I've got mine right here, every employee was given right away a surgical mask and an N95 mask so that you never felt like you were unsafe. Now we have to conserve those and take good care of them. And then finally, I did want to just say that I feel like the disaster management skills that we got from Hurricane Katrina have definitely translated. And also finally, you know, I would say this is an example of never waste a good crisis. It's very interesting that you can fast track some initiatives you've been trying to do for years, things like the home workstations or telehealth. Our IR and neuro IR clinics are now all virtual. In 2019, our whole health system only did about 2,500 video visits for all of our clinicians. We now do more than 3,000 a day. And then there's some other things like we had wanted to do, some kind of Zoom or WebEx for our multidisciplinary conferences for years, and we could never pull it off. And we were able to pull that off in a matter of days. And now we see better attendance across the whole health system in all of our multidisciplinary conferences. So I hope that we are past the peak. Like many others, we're planning very actively for that next phase, figuring out how we can make our patients feel when they come to us in the outpatient setting that we are taking good care of them. I've said many times as we go through the meetings to plan these, we can't have our patients feel like we are not as safe as the Trader Joe's. So we're going to have all those little circles on the floor, or we're going to have plexiglass at our check-in desks. Our patients are going to be drinking their contrast for CTs in their cars. So anyway, I'm going to go ahead and wrap up now for the update from New Orleans. Fingers crossed, we really are past the peak, and we'll be able to kind of manage things as we all move forward to the new normal.
Thank you so much. And now we're going to go to Dr. Judy Yee. She's from Montefiore Medical Center at Albert Einstein in New York. Dr. Yee.
Hello, everybody, and thank you for having me on the panel. We've sort of come full circle in that, yes, we're located in New York City, but I think many of you know that Montefiore Medical Center is located in the Bronx. So we have a lot of parallel similarities to what Dr. Kazam talked about at Weill Cornell, but also some significant differences. So we're located in the Bronx, and we serve the underserved. I think the first inkling that I got that this was something serious was, I think many of you might have heard about the New Rochelle cluster. There was a nidus in New Rochelle, and they developed a quarantine. And I actually had several faculty who were immediately quarantined as a part of that cluster. It seemed like in less than a week, our ERs became flooded with COVID patients and really overtook all of our ERs. Just to give you a sense of how overwhelmed our system has been, we currently have just a slightly less than 2,000 COVID positive patients in our system right now. So the differences, I think, compared to some of the others that you've heard from tonight, is that we serve a patient population, large African American and Hispanic patients who have comorbidities. They have the inability to perform social distancing. And so the patients who came to our ERs were typically, in a high percentage, over 75%, were African Americans and Hispanic. And this was really tough because we soon found out that in this patient cohort, we had the highest case fatality rate in New York City. And because of how quickly the speed of COVID was really tough, and we evolved in our supply of PPE, ventilators, even the medications for patients on ventilators. We're in a good state now, I think, but it was, I think, tough at the very beginning, particularly within the first week. We learned quite quickly, and I'm so impressed at how the health system reacted. Within, I would say, 1 to 2 weeks, we built literally over 11 new ICUs and new inpatient medical wards to accommodate all of these patients. On the imaging side, we had to do, I think, a lot of education of our techs for safety. And that's one thing I think in leadership that you need to assure is that, you know, our techs, even our residents and our attendings in patient interfacing situations have not dealt with or had to have dealt with donning and doffing PPE. And quite often they were doing it incorrectly. They needed daily reminders on what to do. We had to have folks help teach and educate at all levels about safety. And it was also the hand hygiene. We had to really look at our resources as well and designated specific CT scanners for COVID positive patients initially. And then we wound up not having really to do that because most of our patients wound up being COVID positive. We found out that we didn't have enough portable X-ray units. And so fortunately, we have great vendor relationships that we have really worked on over the years, and we're able to get fairly generous trials of portable X-ray units throughout our health system, and we received them quite quickly and dispersed it to the areas of high need. PPE, the N95s were tough, as I mentioned before. Face shields became tough, so we actually had our 3D imaging lab and 3D printing lab start to print these on site. And now, over the course of several weeks, we've literally printed thousands of them and dispersed it throughout the health system. And that has really been very helpful. We have a lot of research, actually, as well. And as this evolved, a lot of the research labs were closed. And they were also a source of PPE for us, actually. So think about using and getting PPE from research labs if you're in a situation like ours. In terms of how you address leadership through these unprecedented times, I think obviously you have to try to be as adaptive as possible to really work with the hospital leadership, but also to work with your team. And I think that you can't understate situations and you shouldn't overstate situations. Being honest and transparent in what the hospital leadership is doing, and as others have mentioned, clear communication, I think, is critical. So as others, we have our daily huddles with daily updates. I personally send out email updates to the team at least twice a week with specific radiology updates. We have our leadership meetings. We are in a situation also now where we have deployed our radiology residents to the front line. And I would say that probably close to at least a third to a half of our residents have been deployed, and this is continuing. Overall, I check in with each one of them personally, has been received very well. They, I think, initially had anxiety, but they were fully supported in multidisciplinary teams, and were not put in situations where they had to deal with advanced COVID positive patients. So I think that decreased the stress and anxiety for them. But I personally check in with them on a regular basis to let them know that if they have a need, whether it be for PPE or anything else, that they have a direct line to the chair, and I think that's been very helpful. I think it's important in these times when I feel, a lot of my regular meetings have been canceled, but the time is now filled with other meetings, virtual meetings, but so much more in working with the faculty and some of the personal issues that they've had. And to delegate is important, and be, I think, careful to make sure that you're delegating to other leaders in the department to empower them to help you to make decisions. It's a learning experience for them as well. None of them have gone through it. None of us have gone through it. But it really is, I think in a crisis situation like this, I'd like to use it as a learning experience for everyone. And I think that they've been very thankful for that. I think that also we've had to really adapt to new workflows. For example, our portable ultrasounds and all the ultrasounds that we do, we decided that a radiologist would personally screen all requests and tailor the exam to answer the specific clinical question, and that was it. And there was nothing, no extra images were obtained, and really sort of shortened the exam times, and our techs really appreciated that. We did that with CT as well. It's important to be really, I think, as you lead a large team, and under me I have about 750 employees spread over 4 hospitals and multiple outpatient centers, that you be, again, clear in your communication, but very organized and strategic in how you redeploy. Because as we closed our outpatient imaging sites, we had to move and shift employees to other sites, and trying to match up their skill sets with what was needed. And sometimes it didn't match as well as we would have liked, but it required, I think, some of the staff to learn new skills, and to try to be as supportive as possible, I think is important. And again, so I go back to using this as a learning experience to educate your staff. I think it's really important also as a leader to be empathetic to the personnel. It's going to be different based on whether you're dealing with technologists versus nurses versus the residents versus the attendings. And you'll find that a crisis like this brings out, I think, the best in people, but sometimes, unfortunately, it brings out not the best in people as well. And so you have to deal with all of that. I think trying to make everybody feel supported, but being fair and transparent in how you're doing it is very important. In working with the health center, there are certain things that they can help with, where they can support your staff. So our staff had issue with transportation, so our health center was able to get no-cost car rentals for the staff, as well as bicycles. to supply free hotel nights for those frontline healthcare workers who did not want to go home and potentially expose their family and young children. Supplying meals and making available, and the Einstein medical students were very good about this, making available childcare also for frontline healthcare workers was very important. So I think we developed well-being resources and distributed that, and that's a highlight of my updates that I give on a regular basis is important. Stay positive. I think everybody looks to you as the leader, and if you are uncertain or if you are stressed and show that, that trickles down. And so it's important that they trust you, that they know that you're doing your best to support them. Initially, it's going to be the PPE, but once you get over that hump, I think it really is the regular and consistent communication. Be confident, be kind, be fair, be transparent. We also celebrate our wins, and I personally will go out and talk to our frontline techs and healthcare workers to congratulate them for something well done. We hold breakfasts for them as well as luncheons, appropriately socially distanced, of course, but they really appreciate that. And again, I reach out personally with phone calls and emails if there is a death of a family member of one of our workers. I will personally reach out to that individual as well. So we've learned a lot, I think, over the past, I would say 5 to 6 weeks. It's hard to believe it's in that short period of time. We have, I think, reached our peak, and I just instituted what I call my P3, which is my post-pandemic planning task force, and have pulled together some of the leaders in the department to look at a phased approach in how we will reopen, assuring safety for both our patients and our staff. So thank you again for having me.
Thank you very much, Dr. Yee. Now we're going to go into the Q&A session, and Dr. Rubin is going to take over.
Jeff, you're muted if you can hear me.
Sorry about that, everybody.
Hey.
Here I am. Yeah, I was just expressing appreciation and thanks for the inspiration and the generosity of our presenters who really, I think, treated us to some tremendous insights into leading through crisis, into how to keep their teams organized and oriented to move forward in a positive direction. We have a lot of questions, which is fantastic. As was mentioned in the text, we are going to extend this till 8:40. Hopefully you can stay with us. I am going to toss questions out to our leaders, and whomever seems most appropriate, if you have an answer, please just jump in. Open up your camera, pop in, and tell us your view on the question. So, and please continue to submit questions if you have ones that you would like to submit. We'll try to get to as many as possible. The first question relates to radiology residents and how they're being redeployed, and what are some of the responses from the residents being put into these non-radiology roles. Does anybody want to just give a little bit more detail about what are the residents being asked to do, and how they are responding. Jake.
Yeah, I'm happy to speak about this from our perspective at Weill Cornell. So I have to say, firstly, I'm in awe of the residents that are redeployed and the work that they're doing. And I think that our patients are very lucky to have them. You know, your first instinct might be they're radiology residents. You know, they're not as clinically minded as other trainees. But in fact, I think the radiology trainees, when they were in their intern year, were probably some of the best interns. And I think that some of that is going to come back very quickly. So what we've done is our residents, when they're redeployed, they typically go to the floors first. Some of them have gotten directly to the ICU, but they get a little bit of orientation there. And then if there's a need at an ICU, then they'll be deployed there, and they're functioning as resident members of the team, but they're always under supervision of you know, very experienced intensivists and other team members. You know, and our residents are, like I said, I'm in awe because their response has been tremendously positive and their willingness to help. We had a lot of volunteers at the outset when it was voluntary in the beginning. And, you know, it's really just inspiring to see. We had some of the residents go not to our hospital, but to a regional hospital that really needed help. And I think they made a tremendous and are making tremendous differences there. And I can't say enough positive about them for what they've done.
That's marvelous. Let me just keep going with the questions then so we can get through as many as we can. I mean, one question that has appeared several times relates to consideration around restarting routine screening procedures and routine procedures that have been triaged during these crisis times. Would anyone care to talk about their approach in terms of knowing when to go back to more normal scheduling?
I can take that. So, you know, that's been something that we've already started to talk about. And obviously in the state of New York, we're guided by, you know, what the governor also will allow in terms of social distancing and restrictions. However, you know, when we shut down our screening studies and mammographies and such, it really was in parallel with our breast surgeons and with our oncologists, and that, you know, elective surgeries were canceled and deferred. And at that point, it was clear to us that it made no sense. And so it was shut down. And you have to work as a team with your referring physicians, and it has to be multidisciplinary. And something that was even emphasized at our chairs meeting today is that we will have various task force looking at very carefully phasing in opening of our outpatient surgeries, and then the imaging will follow that as well. And when it doesn't make sense, or if we experience a cluster outbreak, we'll be very quick to react to shut it down again. And I think that's key, is to be being willing to recognize that you do have another outbreak, and then to shut down again very quickly.
Thank you for that. And, you know, while we're on the topic of being measured and bringing our departments back online fully, would someone care to talk a little bit about the long-range financial planning and impact that is occurring in your departments, particularly with respect to supporting staff, radiologists, non-radiologists? How are you communicating what is likely to be different circumstances for some period of time?
I can take that. We happen to have a meeting today. It was a webinar, and it was an all leadership meeting. So it was probably about 500 people. So obviously there are going to be financial consequences. There already are financial consequences for all of our health systems. So what we were told we were doing today, number one, they have guaranteed everyone's salary through the end of June. And all of the 2019 bonuses are paid for everyone. But they are asking that everyone in the institution, and this was sort of like a shared commitment, and that was really stressed, will have to take 15 vacation days or the equivalent hours, depending on, you know, what position you're in, between March 9th and July 3rd. basically to reduce that liability on the balance sheets. And then there are other things, there's some, we're going to consider people that we're currently recruiting. So we have a meeting for that next week. I think we're also going to have to wait and see. We have to do some things now, and I do think the fact that it's shared, it's clinical and non-clinical administrators, it's the whole institution locking arms and moving together was very important. But, and of course, we're all, like everyone else, actively trying to get funds from the federal government. But I think having to be a shared commitment is very important.
Yeah. Now, I'm sorry I don't know this, but at Ochsner, are you employed, and is everybody working? Yeah. Anybody? Yeah. Thank you. I think it's an important perspective. It's perhaps a lot easier to handle messaging for the whole group when everybody can, put their oars in the water and row in the same direction. Anyone that is, managing, just radiology as bottom line and looking at ways to, try to meet the financial commitments, but also help in supporting staff and faculty, radiologists, through this.
So Jeff, I can address this. So in terms of University of Washington, certainly the dean has been communicating with all the chairs in regards to the reality on the ground, the estimated losses. We've got the modeling in terms of estimated losses from our IHME group. And generally there hasn't been, at least so far, direct communication in terms of their expectations of what they want us to do. But in terms of our leadership, our finance leadership group, which includes my chair, Dr. Sahani, myself, our business director, and our associate business director, we have been coming up with plans in terms of ways to cut costs in the short term, and being proactive with that. In actuality, a lot of the things we've done, a lot of the other chairs have said we're not going to do anything, and then the dean comes back and says, well, we're going to implement these things. And some of them, a lot of them are things radiology has already implemented. And I think that really helps us in where we stand within the hospital and within the institution. But things like deferring incentive pay, we've looked at deferring 75% of our incentive bonuses to a later date. We've incorporated a hiring freeze for 6 months. And people who already have an offer letter or have signed an offer letter will still be employed by us. But for those positions that we were thinking about hiring, those have been deferred for a later date. And we've also focused on, eliminating TPS payments, temporary supplemental pay for extra shifts. And we're working towards consolidating those into our regular call structure, as well as into our regular daytime coverage. So everyone will be working a little harder, but the goal is to maintain their pay while doing that. In addition, we are really looking forward towards accelerating, and I think some other groups are doing this, but accelerating some of the programs we've been planning to increase our revenue. Increased efficiency in MR, shortened block times. It's something we've been working on for a while, but now we're really actuating it during this downtime. Shortened block times in CT. Some population health metrics that we're incorporating in terms of health and wellness evaluation using imaging. A lot of these efforts are things we're actively working on and actively incorporating in order to really improve our bottom line.
Thank you. Thank you. That's fantastic. Maybe a couple of questions relating to occupational health and safety issues within your departments. One question arose as to the extent to which there are efforts to do contact tracing if a member of the staff tests positive to COVID-19. Are there attempts to have directed intervention and to see who's had contact, or how are you managing basically the risk to co-workers when somebody tests positive?
Yeah. So I can speak to this because we've kind of had an interesting approach to this, and it has been an iterative approach, and it kind of fell in my lap as the operations, the vice chair of operations. But we end up so what ends up happening is for symptomatic healthcare workers, we have a red cap form that people fill out, and through that, employee health contacts them and schedules testing through our drive-through clinic. And usually they test the next day, and then your results come out maybe 6 to 8 hours later with very high volume testing. Our lab is actually processing 5,000 tests a day right now. And so, in that form, whoever's being tested, the healthcare worker puts who their supervisor is. So it's directly communicated to their supervisor, and within radiology, they usually, send it my way, send it to our operations directors, and so we get that information, and from there, we try and track down who these people have had contact with. And we, initially what we did is we communicated it to all, say it's an MR tech, we communicate with all the MR techs, we communicate with all the nurses that were covering MR during that period, and then we communicate with any radiologists that are involved in MR work. And then what we realized is there were some gaps there, that arose. We had one of the researchers say, after, this information, and we try to protect patient confidentiality in this process. We don't share their names unless it's someone who's directly worked with them, tell them, hey, X, Y, or Z was exposed. But outside of that, we don't communicate it. But we did get some feedback, say, from researchers who said, or our psychiatrist who does a lot of the testing for functional MRI, the functional testing, saying, I was in MR, the last day that guy was working, so I may have been exposed. So we really did a much more thorough 360 evaluation of who they could have come in contact with, talking to the person, talking to other techs, saying who else could have been there that day. Really trying to gather as much information as we could, and also engaging our occupational health group to see if they could kind of search the system and see other physicians, other non-radiology employees that could have been in that area that we may not be able to catch on to.
That's great. That's terrific. So excellent breadth of experience, and the iteration really came through. I want to present one last question, and hopefully I get an opportunity for most of you to provide some sense and answer to this. We've heard of a lot of innovation that has been brought to bear under the stress of the crisis. And we've also heard in general that there have been changes implemented that folks have sought to implement for years. And finally, the dam has broken and it's possible. I'm really interested, as is our audience, in hearing a little bit about the innovations that you think really will have an important impact for you permanently going forward, and also certain changes that might be hard to roll back that you really feel need to be rolled back. And so, maybe pick one of those two perspectives, and let's just go down the line and have a quick, 1-minute response. Jake, should we start with you?
Yeah, so I think unfortunately one of the things that we may be fighting for a little bit is a reputation as being a place where we've treated COVID patients. And I think that there's going to be some hesitation from perhaps some of our other patients about coming to a site that took care heavily of a lot of these COVID positive patients. And I think fighting those perceptions is going to be a little bit of a battle, and we're going to have to be very cautious, I think, about safety going forward, at least for the near future. And things like that are going to be, how can we de-densify the reading rooms? How can we ensure the patients can come in and kind of go directly to their examinations? And I think that actually that's going to end up being better for patient care in a lot of ways. So we currently do some online scheduling, which I think is also going to be huge for getting some of our patients back. But we also do a little bit of online safety forms and patient information forms. So those things I think should be done before the patient gets into the practice. Can they drink contrast before they get into the practice? Do they need to drink contrast? Do they need IV contrast? Can we shorten the protocol? So I think at the end of the day, we're going to have a better patient experience where it's a little more seamless, maybe like another industry, where hopefully our patients can kind of come in a very efficient manner and get the answer that they need from the diagnostic study, and then move on.
Marvelous, marvelous. Thank you. Judy?
So in thinking about this, I would say that, I mentioned this before, which is the rollout of construction at our multiple sites has really been very impressive. And space allocation, as you know, is one of the toughest things for a health system to equitably allocate space. Here we've all functioned as one unit, one team. I gave up my auditorium, and that became a command center. And our grand hall became an inpatient medical ward. I think that there will be some permanent changes that will stay, and some that will return back to its original use. But there were some poorly used, I think, space that is better used and better serves patients that we will probably keep. And I think that's one of the lasting COVID effects.
Thank you. Dan?
Yeah, so I think as far as the approach I'll take to answer this is more about change that I see implemented. My situation's a little bit different than the rest of the panelists as far as innovation goes. I think the changes that occurred for us was we accelerated our acquiring our own nights. Before we were using teleradiology services for after hours. We accelerated that. We've gotten our own enterprise packs accelerated, so we've launched that. We did have some rotations, even day rotations from home. I think that since our hospitals are getting used to us diagnostic people not being physically there, we might be able to amplify that some. One thing as far as another change, since we implemented sort of standardized reporting for COVID suspected patients, I think that'll help with our culture of more standardized reporting for other things. Being in a private practice, a lot of our radiologists kind of function and do things as they see fit rather than sort of a unified approach in responding to things. So we've, me and another colleague have built out MIPS macros that we're going to try to roll out, and some very like ORADs, LIRADs, TIRADs type things that, and use this culture of unified response and reporting and try to blossom that out to other things. I think that will be a lasting.
That's superb, fantastic. Dana, let me put you on the spot and ask you about innovations that are going to be hard to roll back that you think need to be rolled back.
I've thought a lot about this actually, and I do think that this rapid transition to telehealth is a genie that will not be able to be put back in the bottle. I've jokingly said to my colleagues, okay, well, I guess the physical exam is dead. It has been surprisingly well accepted in our institution with by both patients and by our clinical colleagues. I could envision a day when the people who are on site at healthcare facilities are radiology technologists, some interventional radiologists, surgeons, proceduralists like breast imagers, and everything else is done digitally. I think that social distancing will have positive economic impacts. You really won't have to invest in the infrastructure. But I don't know what that does for things like the doctor-patient relationship, kind of teamwork as we look for patients and wellness. So to me, that's the genie that can't be put back in the bottle. And I'm not sure where that's going to land us up. This digital disruption we've heard about in meetings for a decade basically happened in a week.
Yeah, remarkable, great comment. And the role of the radiologist in the health system in interacting with colleagues and clinicians. Yeah, a lot to think about there. Mahmoud, your final thoughts about innovation worth keeping or that really should be rolled back?
Yeah, so I think one thing, there's been a lot of positive, and I think the positives that were mentioned by other speakers are similar to some of the things we've experienced in terms of improving our functionality. One thing I did want to mention was one thing that I think worked well for us, and hopefully in the future is something we can continue to do, is engaging the patients and the ordering physicians in this process. So for us, when the decision first came down to postpone elective imaging. There are certain studies that are easy to determine that this is elective. Screening mammography, lung cancer screening, DEXA scans, virtual colonoscopy, CT calcium scoring. Those aren't going to be emergent critical studies, but other things, it's tougher to tell from a 3-word history whether this is a critical study or not as an outpatient, or if it's time sensitive. So what we employed is our automated text messaging system to patients to communicate with patients, to encourage them to cancel their studies, to communicate with their ordering physicians, to determine whether their exam is urgent or time sensitive, and really use that as the determiner as to whether their appointment should stay on the schedule or not. Because we can't, it's very tough for us to determine that urgency. And I think in the future, when things happen, when bad things happen, this is certainly a system that we plan to continually employ. In addition, with procedures, determining time-sensitive or critical procedures, especially when you think about treatment in the setting of cancer and biopsies, engaging the ordering physician is very important, and that's something we work towards.
Thank you. I've taken you all well past our 8:30, our 8:40, but I just want to express on behalf of everybody a big thank you for being so open and genuine with your insights and your experiences. You are heroes, all of you, and we are better for having heard from you. Let me also express appreciation to Dr. Lexa, Frank, for asking me to be able to have this conversation with you leaders. And Frank, please come on back, and why don't you take us through with some final words.
Okay, well, I'm going to start off by also thanking the 5 leaders. This was inspiring. Everyone exceeded expectations, so I was thrilled. So thank you all very much. Thank you, Dr. Rubin. And also just want to thank everybody who was on, who participated. Great questions. And as always, I want to thank Anne-Marie and her team for doing such a good job, Jen Pendo and everybody else who was involved. I'm just going to close. Every time we do anything in the RLI, we like to sort of give people a sense of what you could do next. These are some additional resources from the ACR, not just from the RLI. We also want to acknowledge that there is another session that was just done, which is available on recording from the JACR. And then finally, and all the speakers in one way or another alluded to this, which is that in addition to crisis management, which they're all doing so well, there is a day after. There will be other things to come, and the RLI is here to help you through all the kinds of issues that we face as leaders. So again, a heartfelt thanks to everyone who participated, and we're just really appreciate everybody taking the time tonight. This was fantastic. Thank you.
Thank you.
Thank you so much.